Good evening, and welcome to this public meeting of the Standing Committee on Social Development. My name is Jane Wayellen Armstrong. I am the MLA for Mufi Klitschko Region and Chair of the Standing Committee on Social Development. I will now ask members in the room to introduce themselves for the record, and we will go online after. Thank you.
Good evening. I'm Shauna Morgan, the MLA for Yellowknife North.
Good evening. I'm George Nearsu, MLA for the Mackenzie Delta.
Okay. Kieran?
Good evening. My name is Kieran Testard. I'm the MLA for Range Lake here in Yellowknife, and I have a very bad head cold, so I'm sparing you my germs, but I'm excited to hear from our witnesses tonight. Thank you for being here.
Okay, Mr. Hawkins?
Oh, thank you, Madam Chair. My name is Robert Hawkins. I'm the MLA for Yellowknife Center. I'm not a member of the committee, but very interested in this topic. And so, as always, I'm happy to be here. Thank you very much.
Thank you. Thank you, members. Today we will receive a briefing on healthcare sustainability. Okay, Cheryl's online too. So I do apologize. Okay.
Good evening. I'm Cheryl Yakula. I'm the member for the DETRO. Thank you.
Julian too. Julian?
And yeah, Julian Morse, Emily for Frame Lake. Thank you, Madam Chair.
Okay. Thank you. Thank you, members. Today we will receive a briefing on healthcare sustainability and accountability from the Society of Rural Physicians of Canada. This briefing is part of this committee's studies on healthcare sustainability and accountability in the NWT. Please note, this meeting is being live streamed to the Assembly's social media channel. I would like to remind all members and witnesses to direct all questions and comments to myself as chair, and to wait to be recognized before speaking to help us have a smooth meeting. I will now pass it over to our presenters. Please introduce yourself and proceed with your presentation. Thank you.
Thank you very much, Madam Chairperson. My name is Gavin Parker. I'm a rural physician here in Pincher Creek, Alberta, Canada. And maybe I'll briefly let my two colleagues go ahead and introduce themselves, and then I'd like to, if permissible, just offer the land acknowledgement we usually use to start our meetings.
Yes, go ahead, please.
Hi, I'm Kyle Sue-Milne. I am the current NWT representative on the SRPC Council. Thank you for having us. Sorry, I'm having troubles. So like Gavin, I'm a rural family doctor. I normally spend about 20% of my year working in Inuvik, but today I'm zooming in from Treaty 6 territory.
Good evening, I'm Jennifer Barr. I'm the Chief Operating Officer of the Society of Rural Physicians of Canada, and I'm joining you today from Shawville, Quebec. We appreciate the invitation. Thank you.
Okay, so now we will begin with the presentation.
Awesome. Thank you very much. So I'd just like to begin with our land acknowledgement. The Society of Rural Physicians of Canada acknowledges that we are a national organization with participants and members spread out across the vast and diverse regions of our great country. As we work toward our mission of supporting physicians and learners and the health of rural and remote communities, we recognize that these efforts take place on the traditional lands of many Indigenous peoples. We extend our heartfelt gratitude and respect to the Indigenous peoples across Canada who have stewarded these lands for countless generations. Our work is made possible by shared resources and environments within their territories. We honor their deep connection to the land, their rich cultural traditions, and their enduring contributions to rural healthcare. The SRPC is committed to promoting cultural safety and humility within our organization and the broader medical community. We acknowledge the importance of understanding the histories and perspectives of Indigenous peoples, as well as their unique healthcare needs in rural settings. The SRPC is committed to actively implementing the Truth and Reconciliation Commission recommendations in all our endeavors and gatherings, fostering a more inclusive and equitable future for all. We are, with our colleagues in equally challenged regions worldwide, committed to actively implementing the recommendations of the TRC in the spirit of the United Nations Declaration of the Rights of Indigenous Peoples. And with that, I'm just going to switch back my view here. So I think, so you've got our first slide there. Yeah, and thank you very much for inviting us. And I understand that someone in the room will just be controlling the slide. So if I could ask to advance to the next slide. Perfect. So we're a voluntary membership-based organization. So our funding comes about half from membership fees and the other half from conferences and fundraising that we do on our own. So we're not a governmental organization, and we represent healthcare providers dedicated to ensuring access to high-quality healthcare in rural, remote, and Indigenous parts of the country. And we have approximately 3,500 members across the country. We'll go to the next slide. So the objectives for our presentation that we're going to talk about pan-Canadian licensure, of how funding for training once in practice can be helpful with workforce retention, and the development of a comprehensive rural workforce strategy. So the Northwest Territories faces unique challenges in healthcare delivery, as do many rural and remote areas across Canada. Workforce shortages, retention struggles, and gaps in local training opportunities significantly impact healthcare sustainability. Today, we aim to share actionable solutions that can help improve access to care and strengthen the healthcare system in the Northwest Territories. Rural communities like those in the Northwest Territory face higher turnover rates among healthcare providers, limited access to specialized care, and overburdened healthcare teams. These challenges often lead to delays in care and reliance on costly patient transfers. Addressing these systemic issues requires innovative and collaborative approaches, building a sustainable healthcare workforce. So I'd like to pass things over to Kyle for our next slide.
Hey, so from our perspective, we think that one of the most impactful solutions would be implementation of pan-Canadian licensure. This would enable healthcare providers to move seamlessly between provinces and territories, which would help address workforce shortages in remote areas like NWT. So locums, new recruits, and even seasoned professionals could all contribute to NWT communities without the lengthy delays and costs caused by the licensing process, which is otherwise making many physicians reluctant to fill in gaps that may exist. So streamlining licensure would also make rural practice more attractive, as I should have defined locum. Locum means like relief physicians. So finding that coverage would be easier, and thereby would also help boost recruitment and retention. All physicians working in rural areas need to know that they will easily be able to find locums to help sustain the services they're providing, or to respond in times of increased community need. And in fact, many rural physicians across the country are interested in supporting their colleagues when a community is short-staffed, or working part-time as a near retirement, or even just exploring working regions of Canada that they've never been to or never experienced yet, as they try to figure out where they like to be. So pan-Canadian licensure would lead to workforce mobility and therefore stability. It immediately widens the pool of available physicians who provide help when needed. So currently, the Atlantic provinces have taken a lead on this by forming the Atlantic Registry. We're hopeful that other provinces and territories will follow suit. We have shared a document that summarizes details from a survey of our members who were almost universally in support of this approach. Next slide.
So another aspect that we think could help with some of the workforce challenges in the Northwest Territories is investing in training, in particular training after the core training and once independent practice has started. So investing in training for healthcare providers is essential for addressing the evolving needs of rural communities. Training to equip providers with the skills needed to deliver care close to home, reducing reliance on costly and stressful patient transfers to urban centers. Access to training has also been shown to improve retention of family physicians, build networks, enhance physician wellness, and create more stable healthcare system. So around 2 years ago, we received $7.4 million in federal funding for the National Advanced Skills and Training Program for Rural Practice as part of the Team Primary Care overall envelope of funding, and it was funding by ESDC, and that was to facilitate advanced training for rural physicians across Canada. So within a 1 year time frame, 342 rural physicians across all provinces and territories undertook advanced training to meet an identified need in their community. And there was over 187 rural communities that were represented in this, and over 60 that were Indigenous communities, with an estimated impact on health outcomes for 1 million rural Canadians. We have undertaken some program evaluation, which showed that this did increase care close to home, reduced wait times, and it helped build networks of care between healthcare professionals. 94% of participants identified ongoing training needs. A 5-year program with $25 million federal investment is needed to support the ongoing training requirements for rural health practitioners, so all rural family physicians can benefit from the National Advanced Skills Training Program. We had a number of physicians from the Northwest Territories that participated in the program, and I believe we did submit our one-page summary report on this. And this, we think, is one of the key components to a comprehensive national rural health strategy designed to stabilize, sustain, and grow rural healthcare systems. We'll just move on to the next slide. Another initiative we are in the early stages of working on is a comprehensive rural health workforce strategy, which we feel is critical for addressing both immediate and long-term challenges. This strategy will focus on recruitment, retention, and upskilling healthcare providers to meet the unique needs of rural and remote communities. We urge governments to commit to the development and implementation of this strategy as a cornerstone of healthcare sustainability. Family physicians provide the majority of health services outside of urban regions. Rural health services in Canada are in crisis, with a shortage of family physicians leading to ER closures and reduced access to care. This is also having an impact on urban health systems. Urban hospitals rely on rural health services to prevent overcrowding in the city. When rural is failing, it worsens the constraints and strains on urban centers. Future projections indicate a growing shortage of family physicians in rural areas. There is still no national health human resource plan to address this shortage. A national rural health workforce strategy is urgently needed to ensure access to care for all Canadians, including the needs of Indigenous peoples, rural Francophone communities, and as part of Canada's response to the Truth and Reconciliation Commission calls to action. And next slide.
So why do these recommendations matter to NWT? To summarize, improved workforce mobility through pan-Canadian licensure would lead to more physicians helping meet the needs of NWT communities, including a higher likelihood of retaining physicians long-term. Increased training opportunities, whether through dedicated funding through a program similar to what we've piloted through the National Advanced Skills Training Program, or even through dedicated funding in partnership with medical schools for NWT physicians who can then allocate time educating future physicians like residents and medical students. Programs that involve training people from throughout their journey will absolutely help healthcare sustainability in NWT. And finally, a well-structured workforce strategy that comprehensively addresses recruitment, retention, and upskilling current physicians would result in better access to timely, more cost-effective, and high-quality care. All of these measures would reduce the strain on both rural and urban centers, like Gavin said, and create more resilient rural communities. So as an organization, we believe that addressing these challenges requires collaboration between governments, healthcare organizations, educational institutions, and each individual community. And we are committed to working with NWT to create practical and sustainable solutions. Next slide, please. All three of us would like to thank you very much for this opportunity to share our perspectives, and we're pleased to answer any questions that anyone may have.
Okay. 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 Thank you. Thank you for the presentation. Now I will now ask the member if they have any questions. Ms. Morgan?
Does it for me. Okay, thank you so much for your presentation and for your time this evening. The first question I have is about your recommendation for a comprehensive workforce strategy. Now, some of us have been talking over the past year about the need for a healthcare workforce strategy for the NWT. And I wonder if you could explain what you think are some of the key elements of what a workforce strategy should contain. So for example, I mean, do you want it to focus on simply just sort of recruitment and retention strategies, or laying out exactly, you know, how many healthcare professionals of different kinds are needed in different circumstances? Like, can you explain what a workforce strategy should contain, in your opinion, or what are the critical elements?
Thank you. Who wants to go first to answer a question?
I can take it. Yeah, it's Gavin Parker here again. It's a great question, and thank you for that. It's certainly an ambitious undertaking, and I wish there was a great playbook to operate out of. You know, the way that healthcare, I mean, as you're all acutely aware, the way that healthcare runs in this country is we have, you know, basically 13 plus different systems, you know, that are running, and often, you know, what's happening in acute care doesn't always inform what's happening in continuing care, or you know, primary care versus specialized care. So I think probably at its core, when you're developing these, you know, workforce strategies, is knowing you know, knowing what your needs are and where your gaps are, and I think for communities to look at developing, you know, service plans, so deciding, you know, what can be offered locally, and of course, you know, we would advocate as much as possible for care to be offered as close to home as possible. You know, once you have a good idea of what the community needs are, and then you can start, you know, filling that in with, okay, well, what resources do we need to support those needs? And those are not only the physical resources, obviously, that are important, but the more importantly, like we're talking about, the human resources. And you know, we've seen a lot of different models in how this can work, you know, because there's been such a large shortage of physicians across the country. A lot of communities have become very innovative, and I'm sure a lot of this exists in the remote areas, and even I'm sure the urban areas in the NWT, of you know, using other allied health providers. Now, we're a physician-focused organization, so we wouldn't really you know, have maybe great strategies to identify, you know, nurse practitioners or X-ray technologists and whatnot. But I mean, I think that's the big thing to do. And then where I think the biggest gap exists in this country is just aligning the training institutions with what we actually need. You know, we end up, especially from the physician perspective, we end up overproducing things we don't need, right? And if you look at the unemployment or underemployment rate of, you know, subspecialized physicians in urban centers, it's very high as like 14% in some areas. Whereas, you know, in my home province, we have close to 400 openings for rural generalist physicians. So I think one of the big missing links that I see is connecting what the service plan and workforce needs of rural communities are with the output for educational organizations. So that, that's a huge, I think you have to think of the whole pipeline. And I think you have to think of everything from, we've done outreach activities for high school, kids all the way to having ways to support physicians, transitioning to later aspects of their practice and having some, some plan to support them all along the way, right? Getting them into school, getting them funding, figuring out where they're going to work and supporting them with locums, when they're, one thing we didn't talk about, like we have a national locum database that we developed, right? So when people do need and want time away, deservedly so, that they don't feel like they're abandoning their community, and just kind of filling in all those gaps. But it's a tough job. So those are some of the aspects from my perspective. But I'd be very curious to hear both Kyle and even and Jen as well too, if you guys have some feelings on that.
Yeah, I agree with all of those.
Excuse me.
Oh,
Okay.
Sorry, Madam Chair.
Okay.
Sorry
thank
about
you.
that, Madam Chair. I'll address it back to you.
So, Kyle, you want to proceed?
Yeah, sorry about that. I agree with all of Gavin's points. I just want to add that every community is different in terms of its needs, as well as what it can offer based off of what's physically there, the size of the community, etc. So a lot of the planning does need to start from the ground up to look at, again, like what Gavin said, what the needs are, and to not only develop programs based off of each individual site, but then bring all of those needs up to a next level where those sites can then coordinate with each other, so that plans aren't being developed in silos. But at the same time, it isn't like a top-down approach where someone who isn't living in each of these communities is making all the decisions that, well, this is just how it should be. Because it really has to be both the up top and grassroots all working together in order to make things work.
Okay, thank you. Ms. Morgan, do you have a follow-up question? Yeah.
Well, we'll see if Ms. Barr has anything to add.
Okay, Ms. Barr, do you want to add to
Nothing further to add, yeah. Thank you.
Okay, Ms. Morgan, you can go ahead.
Thank you. And so just my follow-up question is, are there good examples you can point us to of where these kinds of workforce strategies might exist in other parts of Canada, within provinces or within regions, or is this something new that you want to see started, but it hasn't really happened yet? Thank you, Madam Chair.
Thank you. Okay, we'll go to Dr. Parker and then Dr. Sue.
Yeah, thank you, Madam Chair. A great question again. So there's lots of opportunity to be innovative in this space, because it is a tough problem to solve, and there aren't a lot of great examples. One in particular that at least seems aligned through the organization. If you look at the Canadian military, the way that they do their workforce planning is they're recruiting like right at the level of medical school. They're offering incentives, like financial incentives, paying salary and paying for, paying for training. And that's connected with a return and service agreement that all of their trainees are going to sign. And actually everybody that trains through the military system, or virtually everybody, starts off in general practice, so like as a family physician, and then after 5 years, depending on the nature of their agreement, they can actually go back and retrain in specialty care. So that, and again, I'm not saying what they do is perfect, but they at least seem to have a national coordinated strategy, and they know what their needs are, both on base and with their international and operational needs. So that's certainly one way that I've seen it done well. Another example, and I wouldn't say this is necessarily a community built up mechanism, but the Northern Ontario School of Medicine, they And one of our members, Roger Strasser, was the founding dean of that medical school, and they really took they took social accountability very seriously when they started their medical school, and so they have a mandate to recruit students from underrepresented groups, and certainly a lot from Northern Ontario, and they train in a lot of those areas, and I think that's one thing that's a big benefit, and we know that from data and research that we've supported and from other organizations, that the earlier and longer that you expose learners to rural practice and remote practice, the more likely they are to end up there long term. There are kind of some embers or some smoldering elements of workforce plans there, but I do think and I do think something national as well too, even though that isn't the trend in Canada. If there was a national strategy and mandate, I think that would be great. And if you reflect it too, now this is more in the post graduate enhanced training, like we did with our National Advanced Skills Training Program. We were overwhelmed at how many physicians we were able to help acquire skills, and these were short training periods, like like as little as as a month or even less in some cases, I believe. But it was really pan Canadian and had a really big impact. And there's a huge desire for more of that, and our trick is just trying to find funding to continue that. So those are some of my thoughts in that area.
Thank you. Dr. Sue, do you want to add?
Yeah, just a couple things to add. So to add to what Gavin said about Northern Ontario School of Medicine, BC did something similar by trying to fill a great need in northern BC by having medical students and residents train based in Prince George, and then from there they do most of their rotations in smaller communities that previously did not have specific learners or specific training programs. So these learners then become comfortable in these communities. They become integrated and a part of the community because they've been living there. And so for them, that's been huge for not only recruitment, but also retention, because you're much more likely to stay in a place where you feel like you're already a part of the community, you've already made connections, as opposed to going to a brand new place where you don't know anyone and you have to start from scratch. So that's one thing. The other thing is that, in terms of overall health workforce planning, you do have to look at all of the various allied healthcare professionals, nursing, physicians. Everyone works together within the healthcare system. If you have, say, a severe shortage in nursing, well, you're still not going to be able to keep the emergency department open or obstetrics open because physicians can't do all of that. Or if you don't have enough people working in the lab, well, then that really stops you from doing essentially any medical work. Same with X-ray techs, etc. So essentially all healthcare workers, regardless of what area they're in, need to be engaged in this, and very important to not just recruit, but also really focus on the retention piece and helping people who are recruited there feel like they belong in the community. And a lot of that will depend on people already on the ground in those communities, but having even specific funding, for example, the NWTMA provides some funding for social events in various communities for locums so that they can feel more engaged, and just even small things like that can make a big difference.
Thank you. George, Mr. Nursu, yes.
Thank you, Madam Chair. My question is around enabling workforce mobility. How would you feel like, if there was a national strategy where all jurisdictions would be able to compromise sort of, from retaining and recruitment of professionals, because I feel we're here in Northwest Territories, we're very remote, especially going further north, and there's a big shortage of health professionals. How can you give some encouragement or some advice on how to streamline these workforce mobility struggles that we're encountering here in the north compared to other jurisdictions across Canada? Thank you, Madam Chair.
Thank you, Mr. Nirsu. Dr. Sue or Dr. Parker? Guess which one would like to answer that question?
I can start, and then Dr. Parker can add after. So, for example, right now, if, say, an ophthalmologist in Ontario is wanting to fill in for the one ophthalmologist in Yellowknife, they have to go through a prolonged process of getting all of their credentials reviewed again, getting reference letters, getting every jurisdiction they've ever worked in to send a certificate to the registrar saying that they were in good standing, et cetera, et cetera. And all of that comes at a cost, and it takes months to do. And so if the one ophthalmologist wants just someone to fill in for a week so that he can have a break, or if he's ill and he just wants someone to fill in, no one in the country is going to want to go through that process to help out, because it just doesn't make any sense financially and time-wise. But if you have more mobility, then someone would easily be able to come in and help out and continue that service while the one person is on their break. And so in the Atlantic provinces, where they have this Atlantic registry now, where the 4 Atlantic provinces have agreed that all their physicians in those provinces can opt in to be on this registry for all 4 provinces. It's a nominal fee on top of their regular licensing fee, but that offers them mobility to essentially any of those provinces to help out whenever the need is. And a great number of physicians in each province actually opted in order to help out. Whereas otherwise, you have a very limited pool of people who are already licensed, for example, in smaller jurisdictions like NWT or PEI. Places that have a large population, like Ontario, have less of an issue because they already have a larger pool of people. But NWT, as you say, is quite remote. And if you're only depending on people who already are living there, or already very familiar and have been working there, it just becomes a lot harder to fill the gaps.
Okay, thank you. Ms. Barr, as a Chief Operating Officer, do you want to add to Mr. Nirsu's questions?
No, I'm good. I think Gavin and Kyle are handling things. Thank you, Madam Chair.
Okay. Mr. or Dr. Parker?
Yeah, thank you, Madam Chair. I agree with what Kyle said. And I mean, so Kyle and I could have licenses in every province and territory in Canada, but at the cost of about $2,000 to $3,000 per jurisdiction. And as Kyle mentioned, all the paperwork. I mean, so we'd have to spend $30,000 to $40,000 to have that license, and that, from a business point of view, if you're not, earning income in every province every year, it doesn't make a lot of sense. Some of the things that, one of the good things that came out of, COVID is the recognition. That's where I think the seeds for the Atlantic Registry started, right? Is they just, if you're living on a border community, and we have these, borders between provinces that are quite close, and I think that they just really needed that workforce portability. As far as I understand it from a political operational standpoint, the colleges in every province and territory operate under, a legislative framework as specified by their, provincial and territorial legislatures. And so that would be I'm not sure, and I'll be cautious here because I don't want a particular attention from my licensing authority. But when you have a pretty steady income stream, and that you're the only one that can provide it, I think people are hesitant to relinquish those fiefdoms, if I can be so bold as to describe it that way. So that's part of the issue, right? And I think if the premiers and were able to all meet together and decide on a shared approach, that would be great. And Kyle particularly has led a lot of this work on behalf of the SRPC. And meeting with various political people across the country, but realistically, if this could be brought into like a meeting of all the premiers, I think you could really get some traction growing. And then just in general, in terms of like workforce retention, some of the most successful programs that we've seen, and as Kyle alluded to, is the sort of grow your own. So not only inviting people and into train in the areas, and then that ends up, in my community, the majority of Canadian trained physicians that we have there all trained in the same program and in the area, right? And so you're just giving them that opportunity. But I know from work that I've done with other organizations, having incentives and ability to take, kids that are as young as, grade 9, grade 10, and expose them to not just, physician, but other health opportunity, other health professions, and giving them some mentorship and a pathway to get there. That's one of the biggest predictors of people that is going to return to those areas if they're from those areas. And forgive my ignorance, I don't know exactly what NWT has in terms of a territorial strategy for that, but that would be that might be a good place to start, because that's the easiest people to convince to work is people that have already come to know and appreciate the the beauty of the communities that you have up there. So thank you, Madam Chair, for that.
Mr. Nersu, do you have a follow-up question?
Thank you, Madam Chair. In our jurisdiction here in the Northwest Territories, we have a language barrier that's often encountered. We on a daily basis, we can get concerns from our respective communities in regards to medical travel, or mainly escort services, medical escort services that, we have elders sent as far away from, say, my community of Fort McPherson, which is close to the Arctic Ocean, and traveling all the way to Edmonton, where they haven't been probably out of their community, and they're traveling to a city, and we're encountering all these barriers here. But language barrier is a big one, and I don't know how much experience you had with medical travel escorts. We're experiencing a lot of difficulty in that area. I know we've tried everything. We've tried every avenue, but we're still battling it. Would you have any insight on that area? Thank you.
Thank you, George. Dr. Parker, we'll start with you.
Yeah. Thank you very much, Madam Chair. It's a great question, and you couldn't be more right about like the lack of providers that speak in the language that people are accustomed to. My wife, who's a language educator, she often, if she signs her emails with a quote, I can't remember who it's from, but it says that, if you speak to someone in a language they understand, you speak to their head, and if you speak to someone in a language they grew up with, and they're that they know best, then you speak to their heart. And especially when, people are scared and anxious about health problems, that reassurance of someone speaking your language. It's a really difficult thing. I mean, I know in our province, we do have a language line where online interpreters are available to help, that are, trained in medical terminology, that are able to, to provide some of that translation services. I know I've worked with other, communities where they do have, volunteers that make themselves available as well too, like in an in-person basis to do that. It's a complex problem. Obviously one of the biggest solutions is the more that you can keep, services in the local community and not need those, not need those transfers. It's because it's very distressing for patients. One of the things that we've advocated for strongly over the years, related to your question, is rural maternity care. And there was a big paper done that the closer that the closer that the mother's postal code where she lives is to the hospital or healthcare facility where she ends up delivering, the better the outcomes are for both mom and for baby. And if we're not designing a system that works the best for potentially vulnerable people, like pregnant patients, bringing in the next generation of Canadians, and if we're not building a health system around those goals, like, what are we doing? So that's just some thoughts. As much as we can keep that care close to home, I think that helps. So thanks, Madam Chair.
Thank you. Dr. Sue, you want to add to Mr. Nersu's question?
Yeah, so I think, it's obviously a problem that's got multiple different reasons and different approaches for. If we look at Nunavut, there are currently at least 3 physicians there who speak fluent Inuktitut. And the reason for that is because there were 2 of them were homegrown. Well, at least 2 of them were homegrown. One of them has lived there for decades and is married to an Inuk and has learned that way. And so having physicians who are immersed in the language or are homegrown that alone can really help address that language problem, at least locally. In terms of having patients go to Edmonton, via our national advanced skills training program, there were several NWT physicians who got extra training elsewhere and then returned to NWT specifically so that those skills would enable many patients to not have to travel to the city for services that they can now provide because they've upskilled. They've learned those skills that that prevent this really disruptive and really inefficient process. But that being said, I mean, there are some very specialized services that really don't make sense to be offered in a rural community. For example, if you have cancer and you need radiation therapy, well, you can't build a huge radiation facility in, say, McPherson. It just doesn't make sense financially and volume-wise. So inevitably, there will be some patients who will have to travel out for treatments, but having programs cultural and language specific programs, whether it's virtual availability of people who can provide interpretation, or having people on the ground where the patients are likely to go to help them navigate and interpret. I think those could help mitigate some of these problems, although not completely eliminate it. Thank you.
Thank you. Now I'll go to Mr. Testart. Do you have a question? Okay. We'll go to Mr. Hawkins.
Thank you, Madam Chair. I'll just jump in right here. So there's a couple of things that are going on here. Thank you for the presentation, by the way. I want to stress it was very interesting. It's great to hear. Some of the things get me thinking here as I listen to the presentation, and I'll just run through some observations. Frankly, if you're talking to members like ourselves, for folks outside of the Northwest Territories, you would view us as the opposition, or, that sense. But in our case, we're not quite that sense. But, I think to myself, are you speaking to the movers, the shakers in the context of the ministers or the federal minister? And are you addressing them in that way? Because what I'm hearing, if I'm hearing it correctly, is that essentially we need a national registration system that catalogs experience, work history, credentials, and standings. That way, any jurisdiction could tap into it. So there's inter-transfer jurisdictional experience. In the case of a locum, I'm hearing you because, a lawyer can practice in any jurisdiction in Canada. So in other words, a lawyer is a lawyer. They can practice in any jurisdiction in Canada up to, I think, 100 days. And hence, I'm hearing challenges of filing paperwork, getting credentials checked, etc., references, and a system probably would work much better. And the last part I'll talk about is, I have a lady in our city of Yellowknife. I'm trying to get her, I'd like to see her qualified. The Nursing Association has blocked or is slow to respond, I should say maybe that in all fairness, to the fact that they won't credit her even though she has qualified to practice as a nurse in Ontario and in Alberta. So the mobility of skills and acknowledgement and the interchange is challenging. And so I guess really, Madam Chair, my first question is who are you talking to in the context of, say, the National Health Minister about creating a system that it automatically rolls out? Because if every jurisdiction had to do it themselves, we would be just as complicated as we currently are now. And I would view this as a national solution to a national problem. Any thoughts on that? Thank you.
Okay, Dr. Parker?
Yeah, I'll keep my comments. Thank you, Madam Chair. I'll keep my comments brief because I know Kyle will have a lot. It's done a lot of work in this area. So to answer your question, who are we talking to? Basically, anybody that will give us an audience, and that's why we're very thankful to be speaking with you folks this evening. Yeah, so we have had these conversations with the federal health minister. We've had it with a number of people within. I know I've talked to our provincial health minister here in Alberta. We've talked to people throughout government, and that's definitely who we're trying to chat with. And you're right that people. This isn't unique to just the medical profession, and within healthcare, it's a big challenge because I think nursing and probably physician assistants and other allied health professionals probably have similar issues like this. As I mentioned earlier, my wife's a teacher, and teaching has the same issue, right? Someone who has a teaching certificate and has taught for decades in one province finds a lot of difficulty in bringing it elsewhere. So I think the challenge, going back to what I said earlier, is that each one of these independent colleges and for medicine that does our licensure and whatnot, getting them to release the reins on these fiefdoms and find a cooperative spirit is a challenge. But it can happen. Like the Atlantic Registry, and it's not without its growing pains as well too, right? Like there has been some growing pains there, but they decided the overall benefit for their region was to do exactly that, right? And change only happens when the pain of the pain of staying the same is greater than the pain of changing. So I guess we have to find those pinch points, if you will, to make the status quo difficult to live under. Thank you.
Okay. Dr. Sue, do you want to add?
Yeah, so one of the biggest challenges with healthcare is that it is legislated as federally legislated as a provincial jurisdiction, right? So it's delegated to each of the provinces, and therefore that's why each of the provinces has their own colleges, and not every college can agree on the exact requirements needed for a license, especially a temporary or provisional license, where may not have full mobility or full ability to work the full scope of your field. So that's one of the big challenges. But there are some things that are very helpful. One is that for physicians who are fully licensed, for every province, they will meet the same standard in that they have to be certified either under the College of Family Physicians of Canada, which is federal, or the Royal College of Physicians of Canada, which is also national. And so they must meet that same criteria regardless of where they're working. So if they meet that criteria and they're in good standing in whatever their home province is, then the provinces just have to agree to share information with each other so that basically this information doesn't have to be collected from scratch. And so the Medical Council of Canada is developing a credentials database that the provinces and territories can opt to use or not use. And this will contain essentially everything that each college needs in order to determine whether this particular applicant is someone that they would like to license or not. So that's a huge first step. In terms of the Atlantic provinces, each province agreed with one another that A, that they will share information, B, that their colleges will investigate complaints from their members, even if that member is working in, say, another province. So let's say you're someone who lives in Prince Edward Island, that's your home province, but you go to Newfoundland as a locum and you get a college complaint from a patient. So PEI then has to investigate your case in Newfoundland rather than the Newfoundland College investigate an out-of-province applicant, if that makes sense. So that's how they kind of ended up deciding to split the work, because otherwise, without that sort of framework, you otherwise don't know who's going to investigate who, and you don't want to duplicate that work either. So essentially, provinces that are interested just need to talk to each other and agree on data sharing, agree on how this framework is going to work, and as Atlantic provinces have shown, it's not that difficult. Thank you.
Okay. Thank you. Mr. Hawkins, do you have a follow-up question?
Thank you, Madam Chair. Just a quick observation, then a question. I mean, I'm often, I'll say, overwhelmed in the context of how little I know when I hear the phrase the administration and paperwork, and I'm not referring to the registration. I always find that a very difficult, vague statement, and I'm always trying to figure out what that means when doctors say the administrative burden is a challenge, and I certainly hope you could provide some highlights as to what that actually means from your perspective. But Madam Chair, my specific question and my last area is, and I really like this crowd because I really want to use this example or this anecdote. It sounds like we're addressing the symptoms, but we're not addressing the problem. And in your field, you folks know what that means. So what advocacy is being done to address the shortage of these skills? I mean, we can pay more. I can make a bold statement, and I'm going to make the statement simply as we could pay people more. And if we took money from highways to give them to these individuals or professionals or whatnot, that's fine. And we've just raised the bar. But literally, it sounds like in this simple example, we have 100 medical spots open and we have 80 people to fill them, and we're all chasing the same 80, which means 20 slots are not being filled. So to me, it sounds like we're addressing symptoms of by trying to pay people more, convince them to move here, give it a try, pay for their education, etc. But we're not addressing the broader problem, which is the supply of medical professionals. And so where is the gap? Why, from your perspective, why do we have such a gap, and why are we not fixing the gap, say, by opening more medical slots? Should we sponsor medical slots? How do you see us becoming part of the solution on this initiative? Because to me, isn't that really the question, which is we keep talking about we have skill shortage. So why aren't we building more skills? And I'm curious from your perspective on that, from that overall perspective, Madam Chair, and that's really my next area of question. Thank you.
Thank you. Dr. Sue, do you want to go first?
Sure. So the question of sponsoring medical spots, that isn't something that is new. That has been tried in various places, and it does work. Of course, there's no 100% guarantee that the particular person that you sponsor, like even with the return of service agreement, after that agreement is done, will stay where you wanted them to. But we do know, based off of data, that people who are homegrown are much more likely to go back there and are much more likely to stay. And so even if you have a bit of attrition, say 1 or 2 out of 5 that you sponsor end up going to Yukon or somewhere else, you still end up retaining a few that you otherwise may not have had. So out east, Memorial has dedicated spots for students from New Brunswick as well as Prince Edward Island, as neither province has their own medical school. Dalhousie in Nova Scotia has dedicated spots for New Brunswick and PEI. And then Sherbrooke in Quebec has dedicated spots for Francophone students from New Brunswick, and these are provincially sponsored positions, and it, for the most part, it does work, but it does require partnership between the province and the schools, and unfortunately, like everything, there is funding required for that to work. And not just in the medical school level in terms of for medical students, but also in the residency level, because last thing you want is to pay for someone to go through medical school but there's no residency training in your jurisdiction, and they go elsewhere to train, and then they end up just staying there. In terms of your question about the administrative burden, I'll let Gavin answer this, actually.
Oh, well, just to clarify, that was just an example.
Yeah.
The spot I'm talking about, why are we filling the big gap? Like, what is the problem with the gap of why we're always chasing like this profession? I'm not suggesting we should have a surplus, but why is everyone suffering from such a gigantic gap that no one? Does that make sense?
Yeah. So in the early 90s, the funding got dramatically cut for medical schools because at that time it was deemed that we had a surplus of physicians in the country. And without long-term planning, thinking, hey, people are going to retire or people are going to quit and, et cetera. We then went into a huge shortage, and we're still working to catch up. Because one of the problems is, like, if you just say give funding for, say, 300 spots at one school, well, who's going to teach them if you have a big shortage of physicians already, right? You can't have one physician in a clinic teaching like 10 students at once. That just doesn't work. And so then we've been trying to play catch up for a long time. And then once you add on some of the other burdens that physicians are faced with, like the unpaid administrative time, unpaid education time, unpaid blah, 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 and you add on higher cost of living, higher cost of overhead, like higher staff wages, higher rent, higher utilities, everything, then many people just either don't want to do it anymore, or they're not making enough to justify, the stress. And so it's a multifactorial issue, unfortunately.
Thank you, Dr. Sue. Or Dr. Parker, you want to answer Mr. Hawkins' questions?
Mm-hmm. Yeah, great questions. Again, I think you're right. We're all chasing the same, pot of providers that isn't big enough. And the thing is, some insights that we've gained, through our work over the years is that, you may be able to use money to get somebody there, and especially if they don't really have an attachment or affinity for where you're trying to get them to go. But that's not going to keep them there. What's going to keep them there is the community supports, the opportunity for their spouse, the, time away, what are the schools like for their kids, all those other things that make life worth living. And, us doctors, like, honestly, we work on the moon if you give us, a good team to work with and adequately resourced. But, if you had to come home every night to complaints about, where you're living, that's a challenge. I think, having strategies for retention, and then at the, at the beginning end of that, having strategies of recruitment from your own local pool, and whether that's through return and service agreements or, as Kyle alluded to, providing those learning opportunities, right? Like I'm from Winnipeg, and I really actually had no interest in becoming a rural physician when I started medical school, but I had an opportunity to get exposed to rural practice early on through a government-funded program, and then I had repeat exposure and mandatory rural rotations, and I did my undergrad in neuroscience, and I was going to be a brain surgeon. And then the more I hung out with brain surgeons, they seemed like kind of a miserable group, and the rural doctors seemed like a really cool bunch of people. I was like, well, I actually kind of want to be more like them, and that's kind of how I found my people, right? So I think having those opportunities, I think when it gets back to, the pot of people that are out there, getting back to creating that service plan and workforce plan, and really, whether it's encouraging, compelling, mandating, whatever needs to be done to the universities, because as I mentioned earlier, they are overproducing things we don't need and underproducing the things that we need desperately. And how we have and in addition to getting them to have spots and spaces that address what the provincial, territorial, and national workforce needs are, I think that distributed education is a huge benefit, right? If I hadn't had a chance to learn and form lifelong mentorship relationships with physicians up in Peace River and Hinton and places in Alberta and on high level as well too, then I wouldn't, I wouldn't have felt as confident to go out into rural practice. So a number of provinces are experimenting, and implementing more and more distributed education, and that is, potentially one big growth area is supporting preceptors in your own rural and remote communities to take learners. And like I said before, but it's probably worth reiterating that the earlier and longer you get these learners into these communities, the more likely you are. It's one of the, again, in addition to being from the rural area, it's one of the better predictors that the earlier and longer people's exposure to rural care is, the more likely they are to choose that as a profession. Thank you.
Thank you. I do have a question too. Okay. In small communities, we heard many times from many of our community members and our Indigenous leaders. I'm sure Dr. Sue probably heard that before. And last year we had the Dini National Meeting here in Yellowknife. And there I heard a lot of Indigenous leaders talking about improving the healthcare system, especially in small communities. And because we heard about misdiagnosis many times, and by the time the patient gets to Yellowknife, it's too late. So they were advocating to improve the healthcare system in small communities, and we don't get doctors all the time. Maybe if we do, then it's maybe every 2 to 3 months, or we don't have the consistency. So so that's where it's that's where our people are at disadvantage, and so we heard that many times to improve the healthcare system, and they advocated for more doctors, And so I see here in your report, there's over 3,500 members representing rural physicians spanning the country. So can you tell us how many of those are Indigenous doctors, and if they are do they have options of working in their home community? Thank you.
Madam Chair, would it be okay if I had you direct that question to Jen, our COO? She might have a more accurate answer to give than I would.
Okay. Ms. Barr?
Thanks, Madam Chair. So we do not track that. We don't have that information on our members.
Well, that's good. Okay, thank you. Thank you for the information. Thank you, and then that's good to know that. I thought, you would have all those information, but we do need more doctors. Many of our small communities lack the services. So, and I'm sure Dr. Sue, working in Inuvik, have seen all that. So, and it's good. It's good to know. I'll ask. I do have another question, but I'll go to Mr. Testart first. Mr. Testart?
Yes, I figured it out. Okay. Thank you, Madam Chair. So first off, I just want to say I completely agree with a comment that was kind of underpinning this presentation, that if we're not providing services in rural communities, that those issues are going to move to larger centers and result in an overburdened system, and not just for healthcare, but also for housing, for economic measures, and for policing, public safety, everything. We don't get this right and put resources in our most vulnerable communities where people need the most support. It's just going to migrate to larger centers, and in the Northwest Territories, there really is only one of those that can offer the services, especially around healthcare. So this is not just a small community issue. This is a Yellowknife issue, and this is an issue for every single one of us as MLAs. I think this organization as well is really crucial to our understanding of the policy solutions to the challenges we've been facing. This idea of easing credentials or sharing credentials so we can find a way to move people into these jobs for short, even if it's for short periods of time, so we can get people the care they need. we're moving into, we just heard an announcement today from the CRTC that they're going to subsidize internet. We have the advent of Starlink, OneWeb, so there's ways to move virtual services into rural communities as well. So all that being said, we have a lot of the solutions that we've been talking about tonight in some form in our current, at least the NTHSSA. We have, a medical residency program, which is very successful and very popular. That's what we've heard from doctors. We have a locum program that has been historically successful. We have all these solutions are not secrets. They're well known to our healthcare administrators. So my question is, if we know the answers, why are the people in charge of managing our healthcare system unable to implement them effectively? Thank you.
Okay, I'll go with Dr. Sue first, and then Mr. Parker, or Dr. Parker. Thank you.
That's a great question. I always wondered that's like literally the same thing, because here's people on the ground basically telling the powers that be, well, these are the solutions that need to happen. And then the powers that be end up going in a completely different direction, God knows where from. And then the people on the ground are then demoralized because they're like, well, no one's listening to us and they don't care. And so then it's a vicious circle, because when we feel like we're not listened to, we're probably more miserable while at our jobs, and then we will attract fewer people into the field, because no one wants to go into a field where they're going to be miserable or working with people who are miserable. So I honestly don't 100% know the answer to that question. Sometimes it's just differences in opinion, differences in priorities. Sometimes it's their particular constituents they care the most about in order to get reelected. I really don't know. But maybe I'll pass it to Gavin, who might be able to provide a better answer.
Okay, Dr. Parker?
Yeah, thank you, Madam Chair. Yeah, it's a great question, and I've asked the same one, sometimes different intonations and different volumes of my voice. It's a challenge, right? And I often find that, and I'll focus on the Alberta situation here. I find that, with a lot of the bureaucrats that are running the system, change means more work for them, and there seems to be, for whatever reason, an aversion to taking on that more work, and so maintaining the status quo seems to be a big part of the mission. The other thing that I'm frequently frustrated by is a lot of and perhaps this rings true for those of you as part of this meeting. I find that oftentimes the bureaucratic people who are in charge of running these things don't always inform the politicians, the decision makers, and the legislators as to what needs to be done to change, or really give them a good understanding of the system. And it's amazing the insights that politicians will get into the system from spending brief amounts of time with myself or my colleagues. So I think that's a big part of it, and so whether that has to do with incentivizing the maybe more entrepreneurial thinking, and I'm not suggesting anything private healthcare wise, but there's one of the examples I use all the time so let's get back to the universities producing an overabundance of physicians that are struggling to find employment because they're so subspecialized, whereas we're just drowning in primary care and generalist practice. And I say, look, if I have a Ford F-150, right, and if Ford started putting out hot pink or lime green F-150s, and they made a ton of them and nobody bought them, well, that would be the last year they would make them. There's no way a company could could produce an expensive product that nobody bought. They couldn't do that two fiscal years in a row. But that's exactly what we're letting, educational institutions do, is to keep overproducing things we don't need and not produce the things that we do need. So, back to just conclude by saying the thing I said earlier is that the change only happens when the pain of staying the same is worse than the pain of changing. So finding those pinch points and putting people through a little bit of discomfort is maybe the best way to do that. But that's a big challenge that you all have before you. Thank you.
Thank you. Mr. Chester, do you have a follow-up question?
Yes, thank you, Madam Chair. Well, Dr. Parker, we are feeling the pain in the Northwest Territories. I think all of our communities acutely of a very fractured healthcare system. But I want to assure you and anyone else who may be listening that we are listening to our healthcare providers, to patients, and to the ministry as well on what they're trying to do to fix it and the solutions that aren't working, quite frankly. And we've been at this pretty consistently, which is why it's come to this committee. And I think it is very frustrating because for me, you reach a certain point where you've created the report, you've overseen the action plan, you've signed off on everything, and nothing's changed. Like physicians, I know have a much easier setup here because they don't have to operate their own practices for the most part. It's provided by the government, and that's a huge ease. So there are shortcuts here that are supposed to make it more attractive, and they just fundamentally aren't working. But I think you've given us a lot to consider. I think we need to drill down on what's practical, what's affordable, and what can work in the Northwest Territories to ensure we have equitable access to healthcare in all of our communities. But that starts by bolstering the center so we have, we can care for people, even if it means moving them to Yellowknife. But we do need to solve this rural and remote issue because the problems are only going to get worse from here out. So I thank you for being here today. It's been a real conversation rather than more of a Q&A. And I really take that to heart because you're passionate about your work and you help people. And that means a lot to me and my constituents. So thank you for being here. Nothing further, Madam Chair.
Thank you. So that's more of a comment, unless if Dr. Parker or Mr. Sue or Dr. Sue wants to comment on that. Okay. Mr. Hawkins, do you have a second set of questions?
Thank you, Madam Chair. I'll just be brief. I don't want to tie committee up too long, including our witnesses. And I should also, in the same manner, express my sincere gratitude. I think Mr. Tester is quite correct. This is a file many of us share, including the members of the committee, that is near and dear to our hearts because we want to deliver some type of result that not only people can see but feel. I mean, healthcare is not a challenge unknown to many people, and it's nice to see we can kind of inch away and solve some problems. So thank you for your time tonight, by all means. The question with respect to my last question, Madam Chair, just to be quick here, is the area of paperwork, and I'm just wondering what the administrative burden means from your perspective. Because I think that's very key for me to get an understanding from everybody. We started to delve into it on the last set of questions, and I just want to make sure it's absolutely, if not abundantly clear, so I can make sure I take a couple notes, and then I can help understand the language or the esoteric language of, doctors and how they have to deal with these things. Because, I mean, if there's a discussion about trying to make people have a little more job satisfaction, and if the administrative burden is the difference of keeping someone or losing someone, I think that's a wake-up call that that bell cannot be unrung. So please, if you could.
Okay. Mr. Dr. Parker or Dr. Sue?
Yeah, thank you, Madam Chair. So to specify with paperwork, so if we focus on, the process of, obtaining a license in different jurisdictions, it's quite a lengthy process where you have to provide, copies, and usually notarized copies of your, medical degree, your residency training. There's usually letters of
Sorry, sir. I'm only interrupting because I don't want you to go down the wrong path. It has nothing to do with getting a doctor. It has to do with the administrative burden of when we have doctors that say they don't want, they're leaving because they find the paperwork or the administrative burden too difficult or frustrating. I did hear you about the licensing challenge earlier.
Okay. Fair enough. Yeah. I mean, on a day-to-day basis, yeah, the paperwork is quite overwhelming, and it's gotten, this is, heading into my third decade in practice, and it's getting much worse than it's ever been. Between insurance forms and what the government requires for various like income support and medication support and things like that. And to me, all of it seems just an effort to dissuade people from applying, or just trying to set traps so that things get denied, right, and not approved. And so not only do you have the heart sink of having, a couple hours of paperwork to do after every busy clinic day, but then just knowing that more and more of these things, tend to get rejected. And then, of course, your patients who depend, would depend on these services. It's just not, not, it has a big effect on their lives. I think there are some examples of where, from a legislative process, that can be made easier. I know in the UK, for example, so sick notes, that's a very simple thing. Now, that isn't particularly administratively burdensome, but it does take away access from others, because if the only reason someone's visiting, us is to get a sick note, it's a problem, and that's one less appointment we can offer to somebody else. In addition to the fact that you have, a sick person that's now come into your waiting room to spread whatever it is they have. And in the UK, they created legislation that employers could not compel employees to present a sick note for any absences 1 week or less. And so that just went away. Now, employers, obviously, they can have their own plans when it comes to, if they notice some gaps in attendance and things like that, then they can have their own plans for that, but they can't compel, patients and therefore providers to have to offer that. So I think that part is burdensome. I've noticed that there is a little bit of a lack of the type of collegiality that Kyle and I likely would have gone through in our in our education, because people are stressed and they're frustrated. And I find with so few people having family physicians, a lot more specialists are picking up the mantle of having to do some of that work normally that we would do, following on lab tests, and so much so that they're trying to obviate their responsibilities. I often get letters from specialists saying, "Oh yeah, I agree with you. There could be something going on here, and you could think to order, this, that, and whatever tests." And it's like, well, I know why they're doing that. It's so that I become the one that's responsible for that test and the one for responsible following up. And I understand why they're doing it, because they're similarly overwhelmed to us. But we're, you get downloaded on a lot as a family physician. So those are definitely some of the challenges that I see a lot, and I think there is some space in there for legislators like yourselves to make that better for us.
Okay, thank you, Mr. Hawkins. Next I have Ms. Yakalaya.
Good afternoon. Thank you, and thank you for your presentation. My question is, knowing you have 3,500 members across Canada, are provinces implementing the SRPC separately, or say for example Alberta, are all of the physicians in Alberta a part of the SRPC?
Okay, Mr.
Or
Doctor. Okay.
Or just individual physicians that into this program. Sorry about that.
Okay, thank you, Ms. Yakalaya. Dr. Parker?
So no, not all physicians in Alberta or any province are all members. So we're a voluntary organization. There's no, there's no duty or need for people to be members. It's entirely voluntary. We do have pretty good representation. It's difficult for us to know like the total numbers of physicians in each province, because there's different numbers depending on where you look at. But I do know for the territories, like we seem to have pretty good penetration up there, and there's certain provinces like in Alberta, Ontario, BC, that we've got pretty good penetration. And there's places where we still have lots of opportunity, like Quebec. And, Quebec has some different cultural ways they deliver healthcare and even the way they're organized that makes it challenging. But it's not mandatory to be part of the SRPC, and so it's a great question. And like if I could wave a wand and make it mandatory, I might be tempted to do that. But yeah, being that it's voluntary. That being said, anybody is welcome to to join the organization. And speaking of that pipeline process, we as an organization we really try hard to get people involved when they are medical students, and we charge nothing for students, and I think we charge nothing or like $20 for residents. Like it's very cheap, and we highly subsidize their attendance at our annual conferences, and that's just to kind of bring them into the fray. My own attendance at the first conference was subsidized. I was a resident, and I even won an essay contest, so I got all my expenses paid for my first trip, and so I think it was probably a good spend as well too, because I remain very committed and passionate about the work of this organization. So just bringing that back to if you can get in people's hearts and minds when they're early in their training, I think that bodes very well for the future of any organization. Thank you.
Okay, thank you. Ms. Yakalaya, do you have a follow-up question?
Yes. If you said you had people, so what you said earlier is you do have physicians that are coming to the Northwest Territories and they're properly licensed to work here. Is that what you're saying from your organization? Thank you.
Thank you. Dr. Parker?
Thank you. Just to clarify, like we're not a licensing or a credentialing body. Like we're an advocacy group with voluntary membership. So our presumption are when people are registering, with us and identifying themselves as a physician, like we presume they have a license to work up there where they're saying, but we don't vet any of that. We do have a category of members if you're retired or not practicing. We have a reduced membership rate, so which I presume people would choose if they weren't licensed and weren't working. But we don't grant privileges or even track people's privileges or licenses.
Okay, thank you. Thank you. I know Mr. Hawkins talked about the administrative process. So in your key finding or in this summary report, you state that there's 3 obstacles encountered in applying for an additional license. So for the length of time to process, like how long does it take to obtain an additional license? Either Dr. Parker or Dr. Sue-Milne.
Anywhere from 6 weeks to 6 months, depending on the exact requirements. So earlier when I said that the college or the registrar wants letters from every single jurisdiction you've ever worked in, for some of our physicians who have worked for 40 years and have come from other countries or have worked in other countries or may have even volunteered in other countries, they need letters from all of those places. So if you volunteered for 2 weeks in sub-Saharan Africa, they need someone there to write a letter. Like, it is completely ridiculous, but that's what's required. And so those take much longer than someone who's brand new out of school, who has really only worked in one place and can immediately ask people who train them to write them a couple letters.
Okay. Thank you. That is an obstacle. So if there's no more additional questions from the members, then I would like to say thank you to the presenters for the presentations. That was really good and informing. So if there's no more questions, then I would like to conclude this, the public briefing on healthcare sustainability and accountability. So the public proceeding is concluded now. Thank you.